So good afternoon, everybody. It's just wonderful to be here on this Tuesday afternoon, and welcome to our special webinar. I'm Charlene Castle, National Director of Epilepsy South Africa, and our webinars have truly been a successful platform to share important information with you, to engage with you, and what better way than through a platform like this. So our webinar series have been enormously successful. They are sponsored by Sanofi and they are incredible partners of ours. And today I'm joined by three wonderful, wonderful women. And the first one is Dr. Vuyiswe Mandita, no stranger to Epilepsy South Africa. Dr. Mandita, as we know as Vuyiswe, is a practicing neurologist at Netcare Mill Park Hospital. So it's wonderful, wonderful to have you with us again today. And thank you for putting your valuable time aside.
Thank you. Thanks for having me. It's great as always to be here.
Our next guest today is Professor Shastra Bora, and wonderful, wonderful to have you with us. Professor Bora is in maternal critical care lecturer at the Department of ONG at WITS. So it's just wonderful to have you with us and to engage with you and to have you as a guest today. Thank you for joining us, Shastra.
Thank you so much for the invitation. Very happy to be here.
And our third guest today is Lucy Mokyama. Sorry, Lucy. Lucy is a mom. She has epilepsy. She's a mom of beautiful children. And she's joined us today to share her lived experience about being a mom with children and this critical, important conversation today. Lucy is also a bursary of our Epilepsy South Africa a bursary of our Epilepsy South Africa Educational Trust. And Lucy has also recently been elected and nominated to the National Board of Epilepsy South Africa as our youth representative. So very big welcome as always, Lucy, and I hope you're not too nervous today.
I'm not nervous.
Lovely to have you with us. So I think I'm just going to jump in, and just today is really informal. We're going to be engaging and just chatting, the four of us. And I'd like to start just asking Vuyiswe. Vuyiswe, can you just set the platform for us and really just talk to us about what is epilepsy, this thing in the room. We all talk about epilepsy. For us, it's second nature. Can you just frame epilepsy? Could you speak about the basics of epilepsy, the type of seizures? What is epilepsy, the type of seizures, and just the clinical information, just to set the tone for us today?
Well, epilepsy is a disease where one is prone to having seizures. So, a lot of people, when they're diagnosed, they say, but before this, I had never had any, and our threshold for diagnosis is very low, like I've spoken before. But anyway, it's basically one is prone to having seizures, and as per definition by the International League of Epilepsy, is when you've had 2 seizures in a year that are unprovoked. By unprovoked, we mean that we can't attribute to anything else. And the reason for that is we've seen that with the first seizure, the chance of a second one is about 20%, and after that, the chance of recurrence with every seizure goes up. So when we catch the second one, we have to then diagnose epilepsy and treat it. It's also a diagnosis made by clinical history, really. In 50% of cases of epilepsies, MRIs and CT scans and EEGs are normal, So we basically rely on the history of what's been happening to make that diagnosis. It's common, more common than we think. And
you froze for a minute. I'm going to pick up. Yeah, carry on, please.
Yeah, it's common, and there is also that genetic link, you know, and the seizures are different, and the reason being it depends on where they start. We are used to that the type of epilepsy where you have generalized seizures, and that's because they start in the area of the brain that deals with consciousness. So where you have seizures and somebody's having convulsions, that's what we're used to. But that so many different kinds, that depends on the lobe in the brain that's affected at any time. And one can have a seizure whilst awake or whilst having what we call a clouding of consciousness. So it's good to you sort of know what can happen and how to identify seizures and be open-minded about that, because there's lots of ways it can present.
And there's also a number of different types of seizures, right?
Yes.
So we've got generalized seizures, and maybe just pinpoint just two of the most common seizures that we see.
Yeah. You know, an analogy I usually use is that of electricity, seeing that neurologists are called the glorified electricians of the medical field. So, you know, it depends. You know, I always say, you know, if you think of your municipal box outside your house and your main switch, anything that affects that, what is the equivalent of that part of the brain, will cause loss of consciousness and convulsions, or it may be just tonic seizures, and not you know, tonic-clonic, that will cause convulsions. So it may just be a stiffening of the body. But beyond that, it depends on which room is affected. So as we go through the brain and we imagine it as rooms, if it's the motor area, you can be awake, but still have shaking of a limb that you are not controlling. If it is from the sensory side, you can have just a sensory symptom, or feel like something crawling up your one side and then it stops. If it's from the visual area, it gives you distorted vision, in the sense that your visual association area doesn't explain to you what you are seeing, and may replace it with another image. If it's from the temporal lobe, that's the exciting bit, may cause confusion, may cause rage issues, may cause personality changes, and may cause odd dreams, you know. So you can also have what we call automatism, where somebody is involved in a task, they carry on, but then during that seizure, they carry on a repetitive sort of action that they had been doing before that. So it's really vast. We could go into detail, but just those other things that's how to think about it, let's say.
Thank you. There's so much more to ask you, right? And I'm going to I'm going to jump to Shastra, because I just want to. Today we're talking about epilepsy in women. We're talking about women pregnancy with epilepsy, and it's a very close to our heart conversation, right? As a woman with epilepsy myself, it's a conversation that really is needed to be had. And I wish somebody had had it with me many, many years ago, because I became a mom 25 years ago. So could you just share with us, Shastra, the things a woman with epilepsy should consider before falling pregnant, when planning a pregnancy, or even when an unexpected pregnancy has. Yeah, talk to me a bit about that, and let's open that topic.
So I want to say, Viviswa, you are my hero, because it is so difficult to look after patients who have epilepsy, because there's so much we do not know until it's trial and error. In the pregnancy population group, we often see women presenting with tonic-clonic seizures under the diagnosis of preeclampsia. And that's where, you know, our forte comes in, trying to elicit if this truly due to the pregnancy that's induced the seizure, or could there be something underlying? And having your support and opening up a multidisciplinary conversation around this, I think, is absolutely excellent. So when it comes to women, I think we all acknowledge on this webinar, being a part of the panelists together with everyone joining us, is that women are so unique in that throughout their years, from an adolescent to a reproductive, through ages, through pregnancy ages, through the postpartum ages, through the perimenopause and menopause, we undergo significant physiological and anatomical changes. And each phase that we basically enter can pose different stresses on a body that's already so vulnerable. So when it comes to epilepsy and considering the reproductive age group in women, the one caveat that we really have to be very cognizant about is contraception. And this is preventing the unplanned pregnancy. Now, if we look at literature in the US, 45% of pregnancies are essentially unplanned. If you try and extrapolate that into the South African literature and population groups, close to 60% can even be unplanned pregnancies. And this just highlights to us how vigilant we have to be about this vulnerable population group, because mothers are responsible for the generations to come. And it's very important that we support them in that aspect. And that is why I feel that this webinar is excellent, in the sense that it's bringing about awareness, and it's also offering the resources that are available to help people make informed decisions. So contraception, in terms of preventing unwanted and unplanned pregnancies, is extremely important, and we need to afford that all women have access to this entity. The concerns with contraception in epilepsy is that there are multiple drug interactions. The contraception on the anti-epileptic therapy and the anti-epileptic therapy on the contraception. So whilst we know that epileptic therapy essentially does induce liver enzymes and enhances the breakdown of different other chemicals, it does so with the oral contraceptive pill. So when we are discussing contraception with our patients, we actually need to risk stratify and individualize what will be the most pertinent choice for our patient. The intrauterine contraceptive devices are slightly more effective in this group because there isn't too much of a hormonal change, and we can choose options that don't have hormones, for example, the copper intrauterine device. When we start moving through to the other regimens, we need to consider what the epileptic phenomenon is going to induce on these different types of hormones. And that is the estrogen together with the progesterone. Now, estrogen levels in patients, for example, who are on a phenytoin derivative of an anti-epileptic drug, have lower doses of estrogen, and therefore prone these patients at higher risk of falling pregnant. And so we need to be very vigilant in terms of what choices we offer to them. The converse is also true. If we offer a high estrogen dose of a contraceptive pill to a patient who, for example, is on lamotrigine, that estrogen dose decreases the concentration of lamotrigine, which then induces or increases the risk of that patient having recurrent epileptic seizures. And so the choice of the contraceptive is extremely important. It would be really great if we could afford the time, the resources, the staffing, the personnel to actually have pre-conceptual clinics within the epileptic population or those living with epilepsy to try and make sure that we afford these patients the best contraceptive options. So that is one concern in terms of when you are wanting to prevent. Then we move on to the couple or to the mom who is extremely broody and wants to start a family. And we want to protect this pregnancy to the best of our ability for maternal well-being as well as for fetal well-being, in making sure that the maternal fetal unit is cared for during pregnancy for successful and healthy outcomes. This will be preconceptual supplementary support in the form of folic acid, We do know that folic acid, there is an element of malabsorption on patients living with epilepsy who are on anti-epileptic therapy. And therefore, we want to supplement folic acid to try and prevent any features of neural tube defects in the baby that is currently developing. So that would be one entity. The average dose is generally about 1 to 4 milligrams, which is not sufficient in the dietary requirements, especially within our population groups. And so we supplement with 500 milligrams on a daily basis. If we find that perhaps there is an individual who would be at risk of falling pregnant because of, we're trying to adjust different types of anti-epileptic therapy, etc., even if the patient is not wanting to fall pregnant, we would rather have on safety and actually offer these patients folic acid just for the supplementation. So from a pre-pregnancy perspective and very early in pregnancy, we would advocate for folic acid supplementation. And then there's a wonderful changes that every woman goes through in pregnancy, the swelling of the feet, the growing of the abdomen, the enlargement of the breasts. When I had my baby, I was a size 3 shoe and essentially delivered everything. It was a difficult delivery, but everything else was fine. And then I get back home and I find my feet are swollen and I've never been able to fit into my shoes again. And I thought to myself, but this is not in the textbooks. And so for the last 8 years, I've been wearing a size 4 shoe. And that basically reflects into that pregnancy. There's a certain element of it that is just the unknown. And I find that when dealing with the patient living with epilepsy, there is so much that's unknown. And as we move through each trimester of the pregnancy, we need to, as a team, be very vigilant in terms of the physiological changes. So for example, in the very early stages of pregnancy, the patient may be on doses of her medication that she's always been on throughout her entire life. And as we move to the second trimester of pregnancy and the third trimester of pregnancy, there's a higher risk of the patient developing a seizure during the change in trimesters because we need to adjust medication. So because of the increased volume of plasma that's circulating around the pregnancy body to accommodate this newborn, this new being that's developing within her, doses of the medication have to change from trimester to trimester. And so that's extremely important. And then the same is true that after delivery, we need to come back down to the original doses that our patient had before pregnancy. And then we still need to consider at that point what type of contraception we are going to afford our patient and whether breastfeeding is going to be the best option for that baby mother unit. So Charlene, in trying to answer this in a nutshell, there's just so much that you would need to consider. And this unique population group really needs that niche. They need the time, they need the compassion, and someone to really be driven to look after this maternal fetal unit, because it is so important that we ensure our mother is safe during the pregnancy, and in doing that, that we have a happy and a healthy baby at delivery.
Thank you, Shasta. I think that you've said so many valuable facts here, and something that I think in one of our first webinars on epilepsy in women in pregnancy, and we dealt with contraception, like you've mentioned, folic acid came up as such an important supplement for a pregnant woman to be taking. And actually, I'd love to hear from you, weigh in on this in terms of folic acid, and the importance of taking it as a woman with epilepsy. So I'd love to hear you, Yiswe, if you could just weigh in, add to what Shastra's had to say, and also maybe about how epilepsy could affect the mother during the pregnancy in terms of her seizure control. What do you see? What's your experience? And how do we help her to make this a successful pregnancy, like Shastra said?
Sure. Shastra, thanks for making that so easy to understand. I feel like, oh wow, I'm learning some things here. but you're right. I think epilepsy is one of those, especially around women, that one of those conditions that does require a multidisciplinary sort of interaction. And I agree that pre-planning is best, or in the conversation, preconception is best. So my approach to women of reproductive age being diagnosed with epilepsy, and it's funny when I speak to 15-year-olds and I'm like, you may want to have a baby one day, and they're like, but we plan the treatment already then with that in mind. So folic acid is there to prevent a side effect of medication called neural tube defects, which have been found that occur 2 or 3 more times more commonly in women with on anti-epileptics as opposed to women who are not, right? And so the one that is most the ones that are thought to be most responsible or could cause that was the sodium valproate, the Epilim, or so the Navalpro and all of that. So those are the ones that cause up to a 6% chance of having neural tube defects. But then the children can also, as Shastra will probably say can have cardiac malformations and all of that due to medications like topiramate. So there are medications where if we can get away with it, we try and start a woman of reproductive age on medications that are less likely to cause that side effect. But the thinking with folic acid from the neurology perspective is preventing neural tube defects for people on treatment. So generally, it's a rule of thirds, from what we see with neurology, where a third of women who have pre-existing epilepsy, when they fall pregnant, a third of them get better, a third stay the same, and a third get worse, because of all the hormonal changes. So those who have less seizures, they're the lucky ones, and those who stay the same, that's great. But there's a third of women that have a tougher time. So the idea is to have the woman to be as seizure-free as possible, because seizures are so dangerous to a fetus. So some of my patients think, oh, because of these neural tube defects, it's probably best not to be on medication. And you sort of have to take that 1 to, depending on which articles you read, 1 to 3 or 1 to 6% chance with, and maybe a little bit less with folic acid, to a chance of even more serious harm to your baby during seizures because of the blood supply that changes during seizures. So seizures are more harmful than the treatment of preventing them, especially when you are pregnant. So that's the idea. The idea is we need to have you seizure-free, and the drug that does that best is the drug that you stay on from the neurology perspective. But we start this conversation already at at diagnosis. We say we would preferably put you on this drug because we feel that then you'd be safer should you fall pregnant, either planned or unplanned. Then we know that you're on a drug that is safer for your baby. But at the end of the day, the drug that keeps the mom seizure-free is the drug that we want.
It's so interesting just listening to the two of you, because when I had my first child, I was in my mid late 20s, and there was no people talking like we are, or experts addressing this, or openly speaking about the effects, or what I should have been doing. And the biggest thing I heard from my neurologists were, we need to watch your hormones, because if you're not stable, like what you're saying, Reese, where is that stay on the same drugs, let's monitor you. So there was no way guarantees or of except just being monitored and being checked. I was very grateful. My hormones did rage all over the place, and I'm sure Lucy's going to weigh in just now as well. But my hormones did rage all over the place, I suppose, as most women. And I love how you split up the third, Reese, because absolutely some women are at risk of having far more seizures and having absolutely it's dangerous to the baby. And the converse applies. So I just love how you package that. Thank you so much. Shastra, I think I see you wanting to add. Let me hand back to you.
I just want to say it's so important, everything Vuiswa has shared. And I think it's just a vital entity that a seizure is absolutely, more detrimental than the medication. I saw a patient today. She is 29 years old. She's had 7 pregnancies, 3 miscarriages. And she's got 3 beautiful girls at home. She's now pregnant again, hoping to have a baby boy. And we were unpacking all these previous, miscarriages. She was diagnosed in childhood with epilepsy. She's been well controlled on Keppra. And when we started talking, she actually suffers significantly from hyperemesis gravidarum, which is significant vomiting in pregnancy. And as a result, even though she took her medication, it wasn't absorbing. So for 2 of the miscarriages, she had come to the hospital. She was vomiting. 2 days later, she had come back and there was no fetal heart. For the second loss, she was vomiting. Everything was fine. And because she couldn't keep the medication down, she actually had a seizure episode and fell onto her abdomen. And when she arrived to the hospital, we found that the placenta had separated in what we would call an abruptio placentae because of the pressure of her falling on a pregnant abdomen. She's very lucky that she survived the episode, but we lost the baby again. And so these are real life situations. And I think most often people think of a potential developmental delay, they think of a potential neurotube defect, which now with adverse science, some of these neural tube defects can actually be corrected in utero. So our technology has really advanced in terms of how we can afford these babies the help and optimize on the pregnancy. But we see that organic cause as such a massive threat that the deaths that are caused from epileptic seizures become second true. And I think what Vuiswa was trying to say, and I think she was so articulate in the sense that it is more dangerous not to take your medication. And I think that's something we really need to drive home, that this is a disease entity. There is a pathophysiology that needs to be corrected for whatever various reason, be it a genetic background or idiopathic. And we are here to afford that information, assistance, and help to these patients so that we can try and avoid the very severe events that may then cascade from an epileptic seizure. So I think that's very, very important to drive home.
We lost Charlene.
Oh, sure. I'm sure she's going to join us soon. I'm just very interested. Charlene had said that we were going to speak to you just now, Lucy. Congratulations. I love to hear about all of your accolades, and I'm so glad to have such a young, vibrant person, so passionate about the foundation and helping mothers who have epilepsy. So I was just very interested to hear what your experience was being a pregnant mom with the diagnosis of epilepsy and how you managed your folic acid and your medication.
Okay, I have 2 kids, and from what I hear you and Dr. Vuiswa have been saying, with my first pregnancy, the most important thing was making sure that my son is okay, my son doesn't get syndromes or any defects when he's born. So I was removed of certain medication with him, and then I had more seizures with him. With that pregnancy, I had more seizures during pregnancy. During at the end, I think the last days of before I gave birth, a week or so, I was admitted in hospital, and then I couldn't, at that time, I also didn't understand the type of seizures that I have. I heard Dr. Vuiswa also talk about the different aware of the type of epilepsy I had, because I would explain and they would say maybe it's something else, maybe it's this, maybe it's that, test her for HIV, test her for. They were doing like trial and errors. You did mention that sometimes it's like a trial and error thing. So with my first, it was very horrible. And then I remember I had seizures, and when I would tell them, let's say like I'll just fall, and when they come, I'm fine again, because I wasn't having that one where you faint or you take long. It would take like 3 seconds or 2 seconds or less. Like, and when they come, they're like, no, you're fine. Like, it kept like that for days until my dad had to call them and say, you need to give my child like medication, because I didn't have enough medication. Something that I want to tell our viewers, that when you're pregnant, make sure that you have your prescription, your diagnosis inside of that booklet that you get, and enough medication when you go for your antenatal checkups, because that is very important. You might be admitted and they might not give you the ones that the medication that you say you're on, because you have no proof. So that was something that I learned with my first pregnancy, that I have to have my medications with me, because I'll tell them I'm taking this and this medication, and they'll be like, no, you can't be taking that, now take this one, and you can't be doing that while I'm having seizures and at that time I need help. So that was a horrible pregnancy. And then I gave birth with C-section, right? And then I also had problems with the contraceptives. You guys spoke about that, because my first pregnancy was unplanned, and I was not on any contraceptives before then. Then after giving birth, they gave me an injection. I don't know which type. And then when I went for my second injection or third or so, like I don't remember which one, the doctor said to me, but none of those things would work on me, because I went and I was taking a medication also same day. And then he asked me that, are you on this medication? And do you want to use this contraceptive? Like, yes. It's like, no, it won't work on you. And that for me was confusing, because now you're saying, and then I'm like, which one will work? Like, nothing will work. Okay, what are you saying? Because the doctors told me that, like, I remember like the doctor that took care of me during my birth. I remember she said something regarding, how would you fall pregnant when you know you are epileptic? That was horrible, like horrifying to hear. So now when the doctor tells me you can't take this, so it means I'm gonna fall pregnant and I'm gonna go back and experience that thing again. It was hard for me, but then yeah, I because those condoms, I guess I was fine because those condoms. My child was like 7 when I decided to have another child, and now I was older. I could speak for myself. So that helped me a lot. I had a voice of my own now. I would tell them, no, you are not going to do that. You are not, like, I would tell them now, because I also checked on websites. I used to check like tips and stuff like that on the website or on the internet. That was my doctor, honestly. So I remember I went to the doctor early in my pregnancy, and the doctor now did this one of taking care of me, like not just making sure, like removing some of the medication off. Like, because with my first child, they said I must stop taking a certain medication, and I think that's the cause of the seizures throughout the pregnancy. So with my second child, I was never off any medication. Like Dr. Bugiso said that sometimes I don't know, but she said something regarding that the treatment, being seizure free, is more important. So I was seizure free with my second child, and even the C-section and everything was perfect. I didn't have problems regarding epilepsy. I had other problems, but it wasn't regarding epilepsy. Even when I gave birth, they did a C-section, but one that was suited for someone who's epileptic and someone who's had issues with pregnancy and birth. Because with the first child, they did, I don't know how to explain it, but you know, where only your feet is numbed. But yeah, they
Epidural.
did,
You have an
they
epidural.
did that one with my first second. The second one, it was, I don't know, but the entire body thing. If you understand what I mean. So I think with my second child, we were both taken care of. And with my second child, we were both taken care of. And with my first, I also was not aware of, you know, the type of epilepsy I have. Those things where I was not aware. I was young. I was like 20, 21. So I knew nothing. And I was, as you know, at the beginning, you said, I hope today you're not nervous. So I would be so scared. So like I'd be so afraid. I would be so nervous, and I wouldn't say anything. I would just keep quiet.
Yeah.
And with my second child, I was very ready. Like I remember, I would carry my prescription. I would carry my medication. I made sure that, you know, at this time I'm going to do it right, and I spoke about it very early. I think I was two. If it's either I was not pregnant or I was 2 weeks pregnant or 3 weeks pregnant, I spoke about it very early in the pregnancy. I told my doctor very early.
Lucy, you've said so many interesting things, and I want to pick up on two things. First of all, I know how difficult it is as a person with epilepsy to speak about your experience and about your epilepsy. And it really, even at this stage of my life, I still, when I share my story and I share what I've gone through, I still will catch my breath, and I still have to take a step and go, okay, I got this. So I just want to, in terms of finding your voice through your second pregnancy, is just really acknowledge you, because you are now making a difference to other women that are considering falling pregnant, or we're listening to Professor Shastra and Dr. Vuyiswe, and we're listening to the medical side of things, and we're listening to your experience and to my experience. And I think bringing them together is exactly what our webinars always want to do, right? Because we want to show what somebody is going through, and that you've had two such diverse experiences with pregnancy is quite incredible. So one of the things that came out, and I'd like both our ladies, our medical ladies, to just carry on chatting about this, is we've spoken about how critical planning is. Because in planning, you're able to go, okay, you're on this medication now. We're now planning a pregnancy. Can you carry on that medication, or is there time to switch to a known medication that is safer when you're pregnant than an unknown, or mitigate as much risk as you can? So maybe let's just talk to that woman that's planning to fall pregnant. What advice can we give her, Shastra and Vuyiswe? What can we say to her? You are now planning, and this is what we're saying to you should be doing. And I think I'm opening a whole nother can of worms, but just that advice I think is really, really valid. Over to either of you.
You want to go first, Vuyiswe?
I think go first, just right now, add on.
So I think, if in my experience, I would get a patient that would make an appointment, come through to the rooms, we'll sit down, we'll have a discussion, and they would essentially then reveal the diagnosis of epilepsy and say that they are wanting to have a family. And I think we've got to acknowledge that we have two very vast healthcare systems in our country. This is an entity where the individual can actually approach you with their partner or their mom. So they've got a support structure already that understands the disease profile, knows how to look after them, knows when they take their medication, how they take their medication, and has kept the tracking record of, when seizures has happened. And then this beautiful individual comes through to you and says, look, I've been on the pill now for 3 years. These are the medications I'm taking. Am I ready to have a baby? And I think that by the time you come to that decision, you are extremely brave for anybody, even someone who's not living with epilepsy. And so you basically come for guidance to say, number one, is it safe? Number two, if it's not, what entities do I need to maneuver to ensure this is going to be safe? And that's where I would then pick up the phone and speak to Vuyiswa and say, friend, I've got this patient. This is the medication she's on. She's done so well for the last 2 years, but I'm worried there's an intermediate risk here of this baby having a potential cleft palate because she's taking a medication that's into that intermediate risk zone. And the other entity I think is important, that we mustn't only look at the diagnosis of epilepsy in isolation, because when it comes to pregnancy, there are other entities can also flare up. Things like hypertensive disorders in pregnancy that will then incorporate further stress on the maternal fetal unit, will incorporate further medication that will then interact with the anti-epileptics, things like diabetes in pregnancy. So there's many other entities. And so then Vuyiswa and I would have this informed discussion together saying, okay, let's perhaps change this drug for her or alter the epileptic medication a little and see how she does, at least for the next 2 to 3 months, to try and get adequate control. It would be safer for her to conceive on this medication. We've considered the folic acid in the background and make informed decisions with each individual unit in terms of how we are going to go ahead in conceiving this pregnancy in the safest way possible. So I think that going back into what we tapped on the preconceptual counseling, risk stratification, optimization is extremely important. And because it takes a village to grow and to look after this child, we are the village. And so, we form part of that village to help make the informed decisions. So I think working together with the neurological team, together with the obstetric team, will help us empower make these decisions for these patients. And so that's how I would approach it in the very beginning.
Well, you swear. I just love what you're both saying, is that multidisciplinary approach is so important. And I think one of always the things we say is we've got such a limited supply of specialists in South Africa, right, in both disciplines. So to have access to both of you in the same platform on the same hour is truly it's just wonderful for our listeners and the people that engage with us. So yeah, and the village, I love that. Thank you. Vuyiswa, over to you. Please weigh in.
Oh, what can I say after that? After what Shastra said. But just to say from the neurologist point of view, I'll say for myself that, when you first meet a patient and you diagnose them with epilepsy, you're going to walk this journey together. So when it's a young lady, we speak, I speak about it before, like I say, they think about it, where at some point we're going to have to make decisions about your epilepsy because you would like to have a baby. So what Lucy spoke about earlier, it was so unfortunate where the medication was stopped because she's pregnant. And that's the best way to ask for breakthrough seizures to happen. And that's not good, for the babies who are trying to incubate there, Also abrupt changes in medication from our point of view, because we titrate the doses that come to a point of where it's controlled over time. There are drugs that you can't sort of up or down the dose over, abruptly. So if we decide on a dose change, we do what we call cross titration. So if we decide, okay, we're going to change the drug, then that conversation would have been had with Shastra, and we'd have it together and we say, okay, let's change the drug, but we cross titrate. That means we go down on the one as we come up on the other. But what we are saying is, from my point of view, from the neurology point of view, if somebody is already controlled on a medication, we do not want to mess with a winning drug. So there are times where women have been on valproate and have been well controlled, and we've had difficulty along the road getting to that point. And to then stop it for the pregnancy if you think about, you know, neural tube defects, then, you know, that's a conversation we really need to take seriously, as opposed to just have a knee-jerk sort of stopping of the medication, because this is what we're saying about neural tube defects on valproate, and then risking more seizures. Because for some people to get to the point where they're seizure-free, we struggle. And if it's that kind of person, we don't want to, you know, mess with a winning drug. The other thing with pregnancy, you know, Shastra mentioned hyperemesis, and from that neuroelectrical point of view, is that vitamin B12 deficiencies also happen. And vitamin B12 is basically like that insulator of brain and nerve cells that causes that action potential to happen very quickly. So if it's not being absorbed because you're vomiting so much, the chances of seizures happening more are higher. So at least that's something we can check in blood. With regard to that you know, that interaction between the contraceptive pill as well as the anti-epileptic medication, the higher, at least what we can do is look at the blood drug levels of the anti-epileptic medication and to see if those are good enough. And if those drug levels are fine, then we know that the person is getting adequate protection or may need for us to go up on the dose. But with risk of neural tube defects, the higher we go and the more, and certain combinations of drugs make that more of a risk. And that's why we'd have to have that conversation with the gynae to say, if this person is on both these drugs, then perhaps we need to make some kind of change. But the good thing is then we can watch the drug levels in the blood and make sure that we're within therapeutic range for that.
So how often, and between both of you or between all of us, how often do you two recommend then taking bloods during a pregnancy? Because I know for myself when I was pregnant, and yeah, I've had seizures since I was 8 years old. So I've had a huge amount of grand mals, now we call them tonic-clonics, but a huge amount of petit mals. We call them different names through the years. But how do you manage that awareness and those blood levels through your pregnancy? Because it's not common to keep going for bloods during your pregnancy, right? You go to your gynae per trimester for different tests to check on your baby, to check on you, to look at progress. So how does a mom that's managing all these dynamics actually get through her pregnancy? Like Lucy, I heard about all her fears, we can get back to that now, and certainly all my fears I had when I was pregnant because of the unknown. But how do we address that with expectant moms? And what advice do we actually give them? Like, we've shared with them the options of different contraception. We've shared with them the different blends of drugs that can and will. We're speaking about such an important I love your words, but the multidisciplinary approach here. So how do we take that forward with women? What's your advice in that regard during the pregnancy that they should be doing, and that they can be asking their gynae, their GP, their neurologist, as an informed expectant mom? What should they be asking? What should they be doing?
So I think if we have to look at the pregnant woman, in state practice, generally, if there is a mom who has a medical pre-existing condition, she essentially comes through to the high-risk pregnancy unit, where we would look after everything, and we would send an SOS to the respective discipline if there was something, untoward. But most often the communication comes through to say, this is my patient, this is her condition, this is her management. She's currently now pregnant, please assist with the pregnancy. So we would go through an entire evaluation, especially if it's in that first trimester. It gives us a wealth of knowledge. So I would that if anybody had missed a period and suspects they're pregnant, they should quite urgently confirm if they're pregnant or not, because there's so much of information we can get very early in pregnancy in that first trimester. Then you need to individualize the patient you have. How often are you having seizures? What medication are you on? Do we anticipate normal physiology in pregnancy with the normal plasma shifts? Do we anticipate exaggerated physiological changes depending on other profiles in patients? And I'm talking about the underweight patient, the overweight patient, the short stature patient, the patient who has a family history of cholesterol, diabetes, etc. These patients, you would confirm that they are quite high risk, and then you would need to be very vigilant. So if I have an array of medication that this patient is on in my first trimester from a pregnancy point of view, I would want to evaluate at least a baseline level of her anti-epileptic therapy. As we move from trimester to trimester, because of the plasma volume changes, I would at least like to have a level in each trimester. However, if the patient had to have a seizure then in pregnancy, I would do it at that seizure, because we also need to be cognizant that if we overshoot the levels, that can also induce a seizure. So in these patients, you may need to be very vigilant in terms of trying to maintain that therapeutic range because of all the other manipulation that's happening. So I would say if it is only a patient who has epilepsy, has been very well controlled, like Lucy's second pregnancy, we are able to anticipate what we are dealing with. We've got good control. This patient potentially should have at least a level every trimester. And then it would be more frequently for anyone who had more seizures during pregnancy, or if there were more confounding factors that were incorporated in the pregnancy. And then still having said that, every person is unique and would need to be individualized.
I think, and I'm going to ask for you to weigh on that, and I think your closing comment there is so critical and so important, is that no person has the same epilepsy, right?
Mm-hmm.
Every person with epilepsy requires individual management, and so little. We are hoping that so much more is going to be understood about the brain and about epilepsy as years and decades go, because it really is a difficult neurological disorder that requires lifetime management. It might go through periods where it's dormant, but everyone says to me, can it be cured? We swear we always enter this. No, epilepsy is something you live with. It just goes quiet at times, and then you don't just stop your drugs. But for you, Swear, would you like to just add to what Shastra was saying?
Absolutely. I think checking of drug levels should happen when indicated, so not routinely. And because there are various reasons why, and it also depends on the type of drug you're on. So the accuracy of that test with certain drugs is not the same as others. I think with regards to individualizing the patient, absolutely, that I agree with. Like I said, if we struggle to get control of the drugs, of the epilepsy on a certain combination of drugs, when we get to a physiological change like pregnancy, we really it need not be a knee-jerk reaction to changing the drugs. We need to plan and together with the obstetricians, where we decide, we sort of deal with the concerns that we have from the neuro and obstetrics perspectives regarding that. But at the end of the day, both disciplines want less seizures. The less seizures, the better for the mom and for the baby.
Yeah. I think, Lucy, let me ask you, hearing so much, I'm sure some of it's new information. For you, just talk to me about the meaning of today for you. And how are you going, aha, are you having moments, oh, I wish I knew that? And just dig into a bit, because I'd love to hear from you.
I actually wrote down the things that when they were saying them, I'm like, I wish I knew this. Basically, I think Dr. Visa said he would ask, even if you're 15 or you're still in your teens, he would ask them, do you plan on having a baby? I wish I had that with my doctors. I wish I had someone ask me, are you planning on having a baby? All those things, because I didn't have that type of support. And I wish I knew better about contraceptives. All this time I thought I can never use contraceptives. There's none that would work on me. And I think Professor Shastra did say this, the copper something. I think it's the IUD. It's, yeah, she did mention that that one can work. So I took the one that no one can even offer someone. After having my second child, I had a tubal ligation. So if I knew certain things, I wouldn't have taken the decisions that I've taken. So yeah, for me, today is very informational, and I'm thinking someone out there will hear this and at least they'll apply them and not go through what I went through. Yeah, even the planning before you fall pregnant, that's very important. And just I don't know how to stress this, but just having a voice and like having maybe a diary where you put things, your stuff in, your time, the times where you've had a seizure, because I know there's a calendar that we are given where we record, okay, I had a seizure this time. You're having those records will help a person, especially if you are going to you're seeing different doctors. So going to a public hospital, having that information on you helps a lot. And the last webinar that we had together, you mentioned that having a bracelet is also important. I think that will help people that are going to public hospitals. I went to a public hospital and I know how it gets. You see a different doctor, a different nurse every time you go there. So even though you have a file, also being assertive and being able to speak for yourself helps a lot. And being like knowing the information that I know today, I'm hoping someone else will be able to stand up for themselves when they go to the doctor.
Thank you, Lucy. Thank you. Thank you. I want to, something all three of you ladies have mentioned, and that's really the support infrastructure. And I think as a woman who is planning to fall pregnant, who's had an unexpected pregnancy, who is pregnant with epilepsy, I think having that support, I know that support structure is invaluable. Knowing your carers, knowing if it's your mom or dad, your brother or sisters, your cousins, maybe it's not a relative that's looking after you, but that they're part of this process when they're seeing the specialists or the doctors in consultation. And that's something that's come up really, really strongly, because without that carer infrastructure, managing epilepsy when you're pregnant becomes that much heavier. I think as a woman, being pregnant without epilepsy is difficult. And knowing you're at risk of seizures consistently, because the reality is, when I was pregnant, it always sat as a fear in the back of my head, in the back of my mind. Am I going to be okay today? And if I have a seizure, how's it going to affect my baby? Am I going to have a baby who immediately has epilepsy? And these were things that really worried me. Lucy's going, yes. So I think I'm also opening quite a big conversation here, but I'm going to just ask, just in short, Shastra and Vizwe, if you can just give me your input on those 2 points. And then during that, if you can just roll up into advice for the expectant mom or the mom that is pregnant or planning, just a real pearl of wisdom, what we could say to this audience in terms of the moms, because there's been so many nuggets today. So I'm going to hand to Shastra. Let's hand that to you.
I think this has just been so wonderful to explore into Lucy's experiences. I can see how both of them have been so diverse and different from each other. And it breaks my heart a little bit that you needed to have that sterilization when we could have been awaiting beautiful Lucy number 3. And I think you've made some very valid points. And I think your experience has such an advocation for women to know that we are here, for women to empower themselves, to ask the questions, to know themselves, understand their own epileptic journey to ask the right questions for the appropriate management. So I would really engage very early on. I think it's absolutely excellent that Vuiswa is offering the 15-year-old options in terms of how she sees her reproductive life moving forward. And it's never too early to introduce these ideas, these concepts, in terms of knowing what each individual would want. So please engage with us early, wherever your resources are, for the correct information that will be pertinent to you. So you are not a lost 21-year-old Lucy. And you can see how beautifully she's matured to make certain that her second pregnancy was well cared for. The other entity, I think you asked, Charlene, is basically we need to look at the realm of epilepsy as a very vulnerable group that needs intensive care, coming from my critical care background. And by that, it's not only just the IUD or the contraception or taking your vitamin K towards the end of pregnancy, or, just planning. It's the holistic approach. We need to treat women and women who are moving into the realm of becoming mothers like very, very special individuals that need our support. And I think that as much as we keep speaking about the MDT, it really needs to be that village. So as much as we are here in capacity as medical professionals, we also want to offer the compassion behind it, the psychological support, the emotional entities. And I think that holistic drive to ensuring that this disease entity is not dangerous in pregnancy is extremely important.
Thank you, Shastra. Vuiswa.
Yeah, I think, what we've stressed is let's have the conversations, especially before the pregnancy happens. Epilepsy, like you said, is a journey. And when we diagnose it, I consider myself entering part of that journey with someone. And talking about where we're going together is very important to me. And also, when it comes to epilepsy and women, it's great that so many more female specialists are available, because I myself, I'm a mother of 4. I've had 4 pregnancies and have had different difficulties with them. And, when people feel comfortable speaking to a human being, as opposed to that doctor, as opposed to us just providing statistics, that is different. So when you ask the questions, we have an idea of what it is that you are actually concerned about and what it is that you don't know. I often say to people, your face is telling me that I'm not answering the question. What are you wanting me to answer? So ask the questions so that we can plan with you and decide where we're going together.
And I think, thank you. And I'm going to just, again, plan. When you go and see your gynae or your neuro when you are pregnant or you're coming up to pregnancy, write questions, prepare, because the time you have with your medical person is so limited, because it's limited. Doesn't matter. You're not going to have hours. So plan, understand, take as much information as you can with when your last seizures, where, what's your history. So you don't start to give somebody like Shasta and Vuiswa the opportunity to go, okay, I can see who's sitting in front of me, because what I'm hearing you ladies are going to take the time to really understand and care for your patients. And I can just, from a mom with epilepsy, I'm going to say thank you to both of you. I think Lucy is feeling the same. And there's so many other questions. So what I want to just say in a conclusion is that our website as Epilepsy South Africa has a tremendous amount of resources. Please share the resources, everybody, as far as wide as you can. We'd love you to join us as members. We communicate all the time with our members in terms of really important information for people with epilepsy and those affected by epilepsy. And we have a support group on Facebook that is really an incredible platform. So any questions post this webinar that you do have, please post there, because you're going to get a lot of feedback from people online. And we will use that opportunity with your questions to come back to you after consulting with Vuyiswe, with Shastra and other specialists that we work very, very closely with. So I'd like to just wrap up. Lucy, one piece of advice to everybody from a mom with epilepsy. One beautiful closing comment.
I think they should get in touch with Epilepsy SA, because I just remembered something now. My support after I had my son, I got it from Epilepsy SA. I had a social worker. I think my son was 5 months or so, or 3 or 4 months. I had a social worker who checked up on me, and she even helped me find a learnership at that time, because I had dropped out of school. So I'll tell them to get in touch with Epilepsy SA.
I love it, Lucy. Thank you.
I got my support as a young mom to like a newborn from Epilepsy SA. After having my baby, I remember I had a huge support from you guys. So yeah, I just thought of it now. So yeah,
we are a wonderful organization that's nearly 60 years old. So we're all very passionate about Epilepsy South Africa. And thank you all. Thank you all, you wonderful ladies that have been our panelists today. And I look forward to more conversations in this regard. So all have a wonderful afternoon and take care.
Thank you so much.
Thank you. Thanks for having us.
Bye,
Take
everybody.
care. Bye.